Dr. Ravinder Kumar Dewan. Sir is Director of National Institute of Tuberculosis and Respiratory Diseases, New Delhi. He is a professor and consultant thoracic surgeon. He did his MBBS and MS from NAMC and MCH in CTVH from GB Pant Hospital. He has received National Talent Search Scholarship awarded by the National Council of Educational Research and Training during his training period. Sir has many national and international publications to his credit. He has been engaged by the international NGO MSF France to study the tuberculosis surgery facilities in Armenia and Cambodia, and he had developed a protocol and a manual for guidelines for tuberculosis surgery. He is involved in the capacity building and training of thoracic surgeons of these countries to develop a tuberculosis surgery unit there. He has trained many residents and surgeons nationally and internationally, and he has been a referee in multiple thoracic surgery journals. Sir, it's a pleasure to invite us to conduct this CPC. Balamurugan.
Thank you, Dr. Balamurugan, for such a kind introduction, and thank you so much for this honor being given to me. Actually, I nostalgically remember when I was doing MS surgery, my own supervisor, Dr. Vijay Anand, coming here to present a clinical pathological meet. Then at that time, Dr. Tandon used to be in gastroenterology. So it's a matter of great happiness and pleasure for me that you have chosen to invite me also. And as the case which has been allotted to me appears to be really very interesting, I'm sure the discussion which it will generate will be very interesting. So, 55 years old male who presented with pain in the right upper back for 1 year, anorexia and weight loss for 1 year, and a swelling over right upper chest for 4 months. And he had his dyspnea on exertion for 2 months. I think with this history, we have to move forward for next. Started having pain in the upper back, and pain was more in the right side. It has increased gradually in severity over 6 months and became persistent with moderate intensity, and over-the-counter drugs of analgesics which are available showed no response. This history is quite significant, approximately 2 into 2 centimeter size initially, which gradually increased to 28 into 22 centimeters. And 2 months later, a small swelling developed on the lower part of right side of neck, which was gradually progressive in size. Dyspnea on exertion over the past 2 months, and a significant loss of weight over last 1 year. So if I just ask a student for comments here at this stage, definitely something of a serious nature is developing, and possibly malignant nature, because the swelling is increasing quite reasonably fast in size and is also associated with weight loss. And presence of dyspnea, any swelling near the chest, is also significant that it is probably compressing respiratory structures like lung and cardiomyocytes. Now, this history of pulmonary tuberculosis 10 years back, for which he took ATT for 12 months. This is significant because we have seen that whatever swellings in chest or chest wall we see, best of the abscesses when we think of malignancy a lot, it ultimately turn out to be tuberculosis. But it may not be true also, because with a past history of tuberculosis does not rule out any other disease. Hypertension and diabetes for 7 years, which are well controlled. I think these are comorbidities which are present in a significant number of patients in our population. Earlier history of alcohol consumption, which he has stopped now, and no history of tobacco chewing. It's okay. And no history of trauma or surgery in the past. Patient is moderately built and nourished, cooperative and well oriented in time, place and person. Heart rate is 105 per minute, regular normal volume. Blood pressure is normal, is afebrile, and saturation is also okay. And except for mild pallor, I don't think any other thing is there except some enlarged, discrete, firm, mobile, non-tender lymph nodes in the right axilla. Now, this thing actually points to possibility of a lymphomatous region also, with lymph node being present in the axilla, because the history there are 2 swellings present. One in the neck could also be a lymph node. Our mind should start working like that, but now this almost gives away what kind of a patient it is. He has a swelling of approximately 20 into 20 centimeter in size on the right anterior chest, extending craniocaudally from just below the clavicle to upper part of nipple. It's a huge swelling. horizontally extending from right side of the sternum to anterior axillary fold, and it is not extending into right axilla. Now skin overlying the swelling is stretched. No other skin changes, but I think, though the data given to me has not mentioned it, probably the skin is mobile over the swelling. The swelling is not fixed to the skin. But next thing is, there is no erythema, dilated veins, sinus or chest scar over the swelling, and there is another swelling in the right supraclavicular region also, which I think must be here, and it is 4 into 3.5 centimeters in size. So it is also progressing very fast. Skin over the swelling is normal, and palpatory findings, the lump is huge, 22 into 20 centimeters of variegated consistency, firm at most places, but see some areas of fluctuation. So fluctuation again tends to make me think about the possibility of a cold abscess, because cold abscess is especially present in the muscular plane. They do not appear to be so cystic. If they are totally subcutaneous, then they will be cystic. But if they are below the muscular plane in the chest wall, they may become slightly harder because the muscle consistency gives them a harder look. It is non-tender, temperature of the swelling normal. As we say, cold abscesses can be normal, but as such the history is going more towards a malignant swelling. But it being a cold abscess, I am not ruling out. Overlying skin is free, but the lump is fixed to the underlying pectoral muscles. Now, a fixity of a mass to pectoral muscles generally is suggestive of malignancy. Nevertheless, we have seen several times a cold abscess, especially in the intermuscular plane, and those starting from an intercostal lymph node and then coming into the plane between the chest wall and muscles. They also give us an idea as if they are fixed. The swelling in the supraclavicular region is firm, non-tender, and fixed to the underlying structures. Skin over the swelling is free. So as of now, it could be any sarcoma, whether it is rhabdomyosarcoma, lipoma, liposarcoma, or any other which is soft tissue which is present, which could lead to a sarcomatous, a fast developing sarcomatous lesion, and a lipoma and a cold abscess. These are my two differential diagnoses. And of course, we have to move forward. They have given me an X-ray chest also. I think, how should we proceed now? Should we do an FNAC now, or should we do the radiological? Radiological, okay. X-ray chest. Achha, there were other investigations, which except for some anemia, they are all normal. Blood urea, LFT, and other things. That PS is also negative. Viral markers are negative. So now in this X-ray, definitely there is a huge mass lesion present in the right side of the hemithorax. Number one, mediastinum is central in position, and both the costophrenic and cardiophrenic angles are clear. Swelling is imperceptibly merging into the neck tissues. It is difficult to make out whether the bones are eroded or not on the right side, and left side is normal. So along with this, as well as in addition, because the history does not show any sign of the Horner syndrome, so it appears that probably it is not something which is invading into the, it is a tumor present in the superior portion of the lung, which is consistent with Horner syndrome is not there. So this is again a soft tissue mass because it is present in the chest wall also. And with this X-ray chest, I cannot say whether it is extending onto the thorax also, but subsequent pictures. Now this MRI shows that it is extending inside the thoracic cavity also, and it has a mild degree of vascularity and variegated appearance. And the two, I think, detailed description of these two things that I have will be given by the radiologist. Is the radiologist giving it? Yes, sir. I can see a soft tissue mass which is extending onto the percutaneous tissue as well as.
I didn't know I was required to give a detailed description, otherwise I would have carried the entire case along with. So what we saw was a mixed solid cystic mass lesion, which was extending into the anterior chest wall, which had an intrathoracic component as well as a supraclavicular component. So these were three lobulations of the same mass lesion. Sir, do you have any more images also of this? Okay. How do we go back on this? Okay, fine. So it was encasing the subclavian and the axillary vessels, and it was also encasing the brachial plexus trunks. So there was lot of solid component, multiple septations, and are there any CT images also, sir, which we have included? No.
Actually, they were sending a CD from
Okay,
which I could
we
not
had given you all CT, MR and
they had
everything.
given me a CD from which I could not take out all of them.
Okay. So, and another important finding was that multiple ribs were involved.
For it.
So multiple, I think 3 or 4 ribs, the anterior parts were involved in a permeative sort of destruction of the ribs was there, which was extending to the sternum. So this was a mixed solid cystic mass involving multiple bones, involving the soft tissue component, encasing the vessels with supraclavicular, axillary as well as intrathoracic extension. So these were the findings.
These are the findings, and I think MRI brain was also sent, which did not, which to me
MRI brain was normal.
no.
It did not show
It
anything.
did not show anything. Okay. So as a surgeon, it makes me think of two things. Number one, we have to make a diagnosis, and tissue diagnosis of a superficial swelling like this is quite easy in the sense of an FNAC. It will be the first thing we will order it. And of course, as a surgeon, one has to also think by what approach will I deal with to excise this tumor if possible. But in view of the fact that they are already encasing the vessels, it might have reached an inoperable stage already. But if at all such a tumor turns out to be benign, other things are there, the approach which I will think in mind is Chamberlain's approach. But I think the surgeons who have dealt with will tell that later on. Did we do an FNAC? So, FNAC report. Okay, I'm through with this. Final differential diagnosis is a malignant sarcoma, which is extending into the thorax, also into the neck, and most inoperable stage. That's what.
So we also thought of soft tissue sarcoma only malignant and maybe malignant peripheral nerve sheath tumor because it was mixed solid cystic with lot of mixed solid component.
In that, I would say that I could not say whether liposarcoma, nerve sheath, or rhabdomyosarcoma, because all of them will present in the same manner. I think I can't go beyond that.
Thank you, sir. I'd like to ask the audience if they have any possibilities in their mind.
What made you think that
It's fast progression in casing of vessels, regeneration. Weight loss. Weight loss is a history of that. And it's usually the progress being very fast. Maybe erosion we see now. In casing of vessels. What we are doing.
I'd like to invite faculty from nuclear medicine, ma'am.
Good afternoon, everybody. So we had 2 PET scans for this patient. One of the scans was done in on October 2022. So this was provided as a CD to us. And when we saw the scan, there was predominantly a metabolically active mass, this multilobulated mass extending from the supraclavicular cervical region into the anterior chest wall and into the right side of the hemithorax. And as we saw it, it was a very heterogeneous density mass with heterogeneous FDG uptake with solid and cystic areas, predominantly necrotic areas. Subsequently, we were requested for a repeat PET scan, and this was done in December 22 at AIIMS itself. Here you can see this mass has now increased in size, and it shows predominantly necrotic areas with peripheral areas of FDG uptake and solid areas of FDG uptake. It has eroded into the first, second and third ribs. So there is erosion of the clavicle also. And basically this scan, as I remember, was done to define an area of a repeat biopsy, a metabolically active area. Also, so that they could, actually they were not satisfied with the previous FNAC and they wanted another area for biopsy or cytology. And they also wanted to define the extent of involvement, which basically PET would do, whether we have other areas of uptake which would suggest it's a metastatic lesion, metastatic disease, because you know that they were suspecting sarcoma. So whether we had any lung mets or any other bone mets, etc. So it would define the extent of disease, and also we wanted to look at response because they had been treating the patient from when the disease was diagnosed till now. So this was basically why the PET had been done. And again, we said that it's a multilobulated mass extending from the supraclavicular into the anterior chest wall, eroding the ribs, encasing the subclavian artery. And one of our differentials was also a malignant mass, though of course we did not find any other areas which would suggest metastatic disease.
I'd like to ask for
how often do you treat such a rapidly growing mass, such a big mass, without any evidence of metastasis?
Yeah, especially, you see, it is the tendency of sarcomas to grow locally very fast. Generally, they do not metastasize overly. They grow into huge sizes, and we had actually, Dr. Ajit Prasad must have also had series of the masses involving, including the entire hemithorax, and still at a resectable stage. Sometimes because they progress very fast. So that possibility is there, very much there. So that does not rule it out. And this variegated appearance and softening at some there because of necrosis actually also suggests malignancy. Because malignancy, rapidly developing malignancy, makes the tissue vulnerable to necrosis.
I'd like to have a comment from the treating team, sir. Mohit sir.
So first of all, I'd like to congratulate Dr. Dewan to make a diagnosis of sarcoma. Any clinician would have made the diagnosis, seeing the clinical findings, seeing the scan findings, and the sheer load of investigations which you performed in this patient, right, from X-ray to CT to MRI to PET-CT, again a PET-CT, and multiple biopsies, suggests that making a diagnosis was difficult in this case. So ultimately, when we had that kind of diagnosis, even with that histopathological diagnosis, we weren't sure of it because we still made, okay, this is a malignant tumor. So despite the PET scan, CT scan, MRI, and histopathology, which was suggesting something else, we had in our mind that this is malignancy. And because it was involving all the vessels and nerves, so removing it in totality was not an option, it was not in our cards. So our idea was to just debulk the tumor and have more tissue for biopsy for confirmation. This is what we did. So it was simply like in spine position, an entry incision was made over the tumor, and we just kind of debulked the tumor itself and submitted for biopsy. I'll come to the follow-up later on.
Thank you, sir.
Any other diagnosis? Any other diagnosis? Nobody else.
Just for theoretical discussion, we can discuss why not lymphoma or a germ cell tumor, because that can also be a possibility. Go they do this kind of situation.
More outside.
Generally not medial cell, but now we don't know whether it started from medial cell or which to medial cell or no outside.
You can just ask which benign lesion can look like this.
Which benign?
Benign lesion can be so massive, infiltrative, and is it even possible?
Nobody was thinking of benign.
No, but I'm just asking that question. Is there any benign lesion which can look like
I can say, but some experiences that occasionally this plasmacytoma or this, they can occasionally present as a malignancy very fast thing, and then you remove them, they come out, they're not very vascular also. I've had the occasion to debulk many of them from thorax. It's another name also given for that. Pseudotumor. That's sometimes.
See, clinically, this kind of scenario really which comes to mind is a possible soft tissue sarcoma of the chest wall. When infiltrated every area, it's a unresectable. Because we don't only have to see the patient assay, but you also have the imaging. So with imaging and patient condition, the only diagnosis that one could entertain was this. We knew what the biopsy was, and that is why we went back, we discussed everything with the That is why when this patient was discharged with me also, and we took him out for the surgery also, we knew that it's a hardest sector, and we were not going to try, and we were not try, going inside and trying to get into a trouble. One of the vessels get knocked out. At least you have a walking patient who was otherwise walking, eating, drinking, everything, and you end up injuring some brachial or a vessel and will be crippled for life. So our sole aim of surgery was to externally people not get into any risky area, because we were still not convinced that it is what the biopsy would show. And that is why we said, okay, let's remove the big, as much as safely possible and submit it for histology. We might have a, sometimes there can be a combination of the two things, that you have a malignancy and there is a superadded some other problem. So that is what was in our mind. But and that is why we kind of rediscussed, and you had twice PET patient. So clinically, you would not make a diagnosis of the histopathology.
Actually, as Nisha, I don't think the surgeon would even enter for debulking if the diagnosis of malignancy was contested. Because they are very vascular. In small little debulking can also lead to fatal wound. It never stops.
We were very sure that we would not go inside the chest. We would only stay outside the chest and take out.
Also, some evidence in the surgeon that something benign has come out in mechanism of two attacks. Otherwise, no surgeon would even
Not vascular in case and better to leave patient alone.
So we have a 50-year-old gentleman with pain and gradually progressive swelling in the right upper chest. Initially, the swelling was 2 into 2 centimeter, then increased to 28, around 20 to 20 centimeter. So the clinical differences were Ewing sarcoma. So around 3 biopsies and 2 FNACs were performed. So this was the requisition form where there was a right chest lump with the possibility of Ewing sarcoma. So these are the histopathological representative images. As you can see, there are multiple tissue cores. They were adequate and representative of the lesion. So we see these are the muscle bundles, and these are the adipose tissue, soft tissue component which is coming in between them. So these are the representative images from the various parts of the biopsy. It has a mild to moderate inflammatory response, some spindle cells and some clear cells which are coming. And again, these are the vacuolated appearance of these cells, which has some bubbly appearance with occasional over to spindle cells and focal inflammatory response. So in these in these vacuolated cells, you can see some sort of refractive structures which are present inside them. So this is the H&E hematoxylin eosin stain slide. We can find out that few structures are coming in between them. So the inflammatory response is mild to moderate, not exuberant. We are not finding well-defined granular mass. There were no tumor cells which was quite obvious, like a round cell tumor or upfront malignant sarcomas in this biopsy. You can see some clear cells, some focal areas of necrosis were appreciated. So it's a slightly higher magnification and better contrast. You can see those refractive structures which are present between the vacuolated cells. So we went ahead to do with some, so to summarize the biopsy findings, this was the initial biopsy. Some vacuolated cells, spindle cells and scattered inflammation. There were refractive structures and some histocytic response was also there. No atypia, round cells or lipoblasts. No granuloma or a significant giant cell response was present. We went ahead with special stains and immunohistochemistry. So the first thing what we do is, if we are suspecting something else, some parasite, some fungus, some other, we do some special stains. Out of which the commonest one is Alcian blue PA stain. So this is the Alcian blue PA stain. You can see the blue color stains these are the mucinous structure which is getting highlighted in between these cells, and this is the PAS positive structure which is coming up. And so this was numerous. The entire biopsy was full of these structures. Grocott methanamine silver is a silver stain which highlights. It gives a green background, and these are the fungal yeast forms which are having this narrow based budding and they were distributed throughout the tissue. So this is a specific stain for this organism, which we're going to see in the next few slides. This is mucicarmine, which beautifully highlights the cell, the polysaccharide capsule of that. And you can appreciate that it has this clear capsule and distributed throughout the biopsy. And this is a stain called Fontana Mason or Mason Fontana stain, which is done to demonstrate the melanin pigment. It's used for melanoma also and various other tumors. And along with that, this fungal infection is stains positive for this special stain. And so this is a CD68 immunostain, which is also a marker for histiocytes. You can see they are having diffuse positivity for these histiocytes and contains those structures which are positive inside. Now we can clearly see the structure, and the CD68 is highlighting the background histiocytes. So with these findings, so we just summarize the findings. They are variably sized, round to oval, encapsulated, thin-walled yeast forms, which are approximately 4 to 8 microns, and it has narrow-based budding. This imparts a soap bubble appearance, and they are positive for special stains like periodic acid skiff, mucicarmine, silver stain, as well as Mason Fontana. So with this possibilities, there are a few differences which we can consider. The first one is cryptococcosis, second is blastomycosis, and third is histoplasmosis. What are the differences is that one important finding is the variability of the size. So you can see in the previous slides that none of these are uniform. It is not uniform at all. It has variable size and shapes, and it is like in the size is also like 5 to 15 microns. So it has variable size. And in comparison, blastomycosis has a slightly larger size and has a double contour of the wall. Likewise, histoplasmosis is slightly smaller, and it's completely intracellular and studded with the cells. They have eccentric placed nuclei. With regards to the budding, these are narrow-based budding in cryptococcosis. Blastomycosis has broad-based budding, and histoplasmosis has teardrop budding, which may not be seen on an ideal section. So these are the representative images of these individual cases. As you can see that the variability in cell between the yeast form size. Whereas here you can see that the budding is slightly broad-based, and they have this double contour, which is characteristic of blastomyces. However, in histoplasma, you can see that they are studded with these parasites and yeast forms, and they have eccentrically placed nuclei and with slightly smaller size. So special positive stain is mucicarmine and Mason Fontana, which is positive. Mucicarmine is negative in blastomyces. It can be positive for Mason Fontana. Mucicarmine is negative in histoplasma, and the pseudocapsule can be faintly positive for silver stain. So of all the differences which are considered, the probable of this, the definite diagnosis is a cryptococcosis. So along with that, we received a fine needle aspiration cytology, and because of the rapid growth, so you can see that the similar yeast forms are fully studded with this, and these have this background cyst macrophages which are present. So similar structure, same morphology. This was the biopsy which was received just immediately after like a month or something like that. With the similar the biopsy, the previous diagnosis has been mentioned, and since there is a strong clinical suspicion of co-associated sarcomas, or is this because the issue of representation. So these are the possibilities which are mentioned here. So this biopsy is also quite representative of the pathology, and slight comparison with the previous biopsy, this has more of vacuolated appearance and less of an inflammatory response. So they are studded with similar yeast forms of the cryptococcosis and slightly reduced inflammatory response. So this is this classical soap bubble appearance which we get in cryptococcosis. These are completely filled with these organisms. This is again slide on H&E. So one more FNAC and one more FNAC was done. Likewise, the same representation. Again, this was the cryptococcosis. There are no atypical cells in these FNACs and biopsies. So the timeline is like because of the very strong clinical suspicion of malignancy, there were biopsies and FNACs which were performed. And finally, a debulking surgery was done. So the question remains is whether this is only cryptococci or is there any associated malignancy, dual pathology which is present in this. So we are seeing the gross image of this debulking specimen. We have multiple soft tissue pieces which is grayish white, firm and slightly fibrous, and you can see the slimy appearance of the cut surface, so which is very characteristic. And so some areas of softening, necrosis, and hemorrhage were also present. So we have processed multiple sections, and all of them show features of cryptococcosis. There are no evidence of malignancy in this. So likewise, but this had secondary changes in the form of necrosis, degeneration, and there are no atypical cells which are present. So this is the gelatinous edema which is present throughout the tissue, which is quite characteristic of cryptococcosis. Again, this is the bubbly appearance, a space between the adjacent area. So this is a music administration. You can beautifully appreciate the narrow based budding here and the variability in the size of this yeast forms. So some areas of large areas of necrosis and cystic degeneration are present, and necrosis. So these are the necrotic yeast forms, and some viable forms are present. So final diagnosis of cryptococcosis, that's Cryptococcus infection species. So some changes in the form of necrosis and cystic degeneration is present. There was no any evidence of malignancy. So to continue the discussion, so the species characterization was Cryptococcus gattai, and tissue KOH mount culture are all positive for Cryptococcus species. This patient has CS of involvement also. India in preparation, culture, and latex antigen testing was positive for Cryptococcus. So this patient has both in the lung involvement, soft tissue involvement, as well as the CS of involvement was present. So what do we know about cryptococcosis? It was initially described in 1894 in a tibial granuloma by two pathologists, and later it was a major health recognized as a major health threat when the AIDS pandemic started in 1980s. So the two important species complex among the cryptococcosis are Cryptococcus neoformans and Cryptococcus gattai. They belong to the phylum Basidiomycota, and 80% of the infections are caused by Cryptococcus neoformans, and it occurs predominantly in the immunocompromised state. This patient was, this patient is negative for HIV 1 and 2. I think it was repeated once or twice, 3 times also based on the reports. So he has only diabetic mellitus, which is partially immunocompromised state. I don't know how much to comment on that. So this is very important to note here that this occurs predominantly in the immunocompromised state, and the common presentation is meningitis or meningoencephalitis. Whereas this Cryptococcus gattai represents approximately less than 20% of the infection, and it is predilected for the immunocompetent individuals. There are some risk factors which are reported among these patients. So it can also affect the immunocompetent people, and this can also affect the immunocompromised people. But this is the dominant picture which is given. So this here you can this is dominantly affects the pulmonary lungs, and other sites of infection include cutaneous, that is primary cutaneous cryptococcosis. It enters through the trauma tract and it forms as a tumor nodules or nodular appearance. Second is ocular involvement and soft tissue involvement. So this is the life cycle, or this is how it disseminates. So this is they are ubiquitously present in the soil, in the avian excreta, inside the hollow bark of the trees, especially the eucalyptus trees. So these yeast and spore forms are inhaled, and it is the route of transmission is through inhalation. So the alveolar macrophages, it resides inside them. So it depends on the immunity of the patient. So it is latently present. In case of, like for example, if there is HIV, AIDS, and the CD4 count drops less than 200, it reactivates and it spreads throughout. But some patients can develop primary pulmonary disease, and also there can be dissemination into the CNS, causing meningitis or meningoencephalitis. So this is the difference in the epidemiology between Cryptococcus neoformans and Cryptococcus gattai. There is a worldwide distribution for Cryptococcus neoformans, whereas it is present in the tropical and subtropical regions in Australia, New Guinea, and North America, also in British Columbia regions. So found in soil as well as rotting vegetations, which are being frequented by birds and bird guanos. And historically they are found in eucalyptus trees, but also has been noted in trees and soils. In other trees also they have been reported. So the predilection is for the immunocompromised people, and largely affects the immunocompetent people. So given that this is how it enters, how does the body respond to Cryptococcus? So these are the alveolar macrophages where it is inhaled. Since it's a small size, it enters deeply, and these are the inside the alveolar macrophages there are pattern recognition receptors which recognizes that this is a pathogen, and it mounts a inflammatory response by release of chemokine CCL2. Among this, there is recruitment of the dendritic cells as well as monocytes, and this inside the dendritic cell there is antigen presenting to the Th1 Th17 lymphocyte. So upon this is the most important cell which gives this cell mediated immunity, and there is release of this interleukin 6, 10, interferon gamma and GM-CSF, by which there is transformation from the subset switching to M1 macrophage, which is responsible for containing the granulomatous inflammation. Inside the macrophage, there is release of INOS, CD80 and TLR4 receptors so that it is contained and a well-formed granuloma is formed. This occurs in an immunocompetent person, whereas in an immunocompromised patient, this is not possible and there is chance of dissemination. So when there is a decreased response, there will be increased amount of cryptococcus species where there is dissemination. However, in case of where there is an exaggerated immune response, there will be tissue damage and damage to the native tissue. So what are the risk factors which you all know? It is cryptococcosis is the one of the AIDS defining illness, meningitis. So HIV is the important AIDS infection. HIV/AIDS is the important one. Other conditions include systemic lupus erythematosus, rheumatoid arthritis, where patient receives corticosteroid and immunosuppressive therapies, solid organ transplantation, malignant and lymphoproliferative disorders, sarcoidosis, renal failure or peritoneal dialysis, diabetes mellitus. It has very low risk given, and treatment with monoclonal antibodies, anti-GM-CSF antibodies inside the CSF, idiopathic CD4 positive lymphopenia, in cases of decompensated chronic liver diseases, and hyper IgM or hyper IgE syndrome. So these are the main important risk factors. So all these said and done, what decides which patient, how does it respond? So in key virulence factors which are presented by the cryptococcus for immune evasion are, important thing is the polysaccharide capsule, and there is this formation of melanin which we demonstrated in the special strain, and there is thermotolerance. By these three mechanisms, they inhibit the phagocytosis, prevents the migration of the leukocytes, and inherent antioxidant will neutralize the reactive oxygen species which are done to neutralize the pathogens, intracellular pathogens. So this is by the organism. So what do humans have? If there is any polymorphism in the important component of the immune response, so there will be defective immune response, like polymorphisms in the Fc gamma receptors, mannose binding lectin, lectin-2, toll-like receptors, macrophage colony stimulating factor. This increases the susceptibility for infections. So there is a variable host response, as we saw that initially there was some sort of inflammation, and the later biopsies we are seeing only sheets and sheets of fungal profile. That depends on the place and allows the immune status of the patient. If the immune status is good, it can contain inside the granuloma, you will see only sparse organism, and it can even have a myofibroblastic response. It imparts a pseudotumor appearance. And so these are the basic immunology about cryptococcosis. What is so special about this Cryptococcus gattai? It was first recognized and described as a distinct strain from Cryptococcus neoformans in the year 1970. It is a species complex under which there are 5 organisms, that is Cryptococcus gattai, Deuterogattai, Bacilliosporus, Tetragattai and Decagattai. There was an outbreak in 1999 in Vancouver Island, upon which the research interest shifted to this particular organism. So there are morphological differences between these two species. The mean cell diameter and the capsular thickness is more in case of Cryptococcus gattai. The ability to transform itself into a giant cell that is seen in Cryptococcus gattai. They are also called as titan cell. There will be up to 50 to 100 microns in diameter. However, in case of neoformans, there will be capsular shedding and microcell formation. So why is there a difference in response? As we initially told, there is a predilection for pulmonary infection in case of gattai, whereas CNS infection in case of neoformans. So this is the reason why there is already dendritic cell response in mouse models. They have demonstrated that they have the immune evasion mechanism, and there is dampening of the activation of this Th1 Th17 response in case of gattai. So this is the differences in the immune mediated response between the gattai as well as neoformans. You can see that once upon inhalation, the yeast forms or the spores enters into that and starts multiplying, and it has a thick capsule, thin cell wall and cell body. So there are multiple mechanisms which just briefly say that it tries to evade the macrophage killing as well as simultaneously proliferate. However, in case of neoformans, it tries to shed its capsule, try to remain latent most of the times. It waits till the immunity weakens, and once it weakens, there is proliferation and extension. So there are some mechanisms. I don't want to illustrate much further than this. And there is a predilection for involvement of the meninges because of the ability called as the Trojan horse mechanism. It hides inside the macrophage and passes inside the blood-brain barrier, along with multiple other reasons. So this is the reason of this predilection for lung as well as predilection for CNS. So we'll just quickly review the some studies which are done. So why they have done some large series studies where cryptococcus is in immunocompromised patients. Among 46 patients, 20 patients were apparently immunocompetent. They did not have any risk factors or HIV. So some risk factors in the other group were ESRD, cirrhosis, autoimmune disorders, diabetes mellitus, which we have previously discussed. Among these 20 patients, 3 had Cryptococcus gatei and rest were all formed by Cryptococcus neoformans. In this series, however, there was a predilection for CNS infection in case of Cryptococcus gatei. So similar presentation like our case, there is the chest wall mass and rib osteomyelitis associated with the use of fingolimod, that is a disease modifying agent in case of multiple sclerosis. So likewise, we are seeing that there is a chest wall and rib destruction and containment and this presence of Cryptococcus. All these cases were negative for HIV and all these cases were caused by Cryptococcus neoformans. So this is one, like when there is therapies to for modulating immunity as well as immunosuppressants, this is one series which highlights that. There are multiple series which demonstrates that there are cryptococcal infection in the form of soft tissue abscesses and arthritis. This case report highlights the 66-year-old female who's a renal transplant recipient, and she had developed infection in the soft tissue around the joint and formation of abscesses. So this is a slightly older report where it says there is cryptococcal myositis and necrotizing vasculitis and a necrotizing soft tissue infection in case of cryptococcosis. So some reports to highlight them. This is a very interesting thing where, so like in our case, as sir mentioned, there is a possibility of pseudotumors which are induced by this cryptococcosis. In this series, they have found out that there are like 5 cases of which two were males and 3 were female. All these cases were HIV positive. As I previously said, it depends on the inflammatory response. Like what we all know that there's tuberculosis in immunocompromised patient can produce tubercular pseudotumor like appearance. So there are multiple, there are few organisms like Mycobacterium actinomyces and Klebsiella which can form a tumor response. In those cases, they have found out that along with the histiocytes, there is a myofibroblastic lineage. This proliferating myofibroblast gives the appearance and the ability to contain that inflammation as a soft tissue tumor. Here you can see that this is a CD68 IHC and mucicarmin stain. Unlike our case, there is very sparse organisms which are present here. Only few organisms are present. In the same series, they have found out that there is other cases where which can show increased number of organisms. So this pseudo tumor like appearance has also been documented. Like many other infections, like especially Mycobacterium and immunocompromised. This is also quite common. So the take home message and the summary is that Cryptococcus gatei is masquerading as a tumor, and the presentation as a soft tissue mass and infection needs recognition, and it can also affect apparently immunocompetent patients. The diagnosis can be done by morphology and special stains. I'd like to acknowledge Dr. Adarsh sir for giving the case, and Dr. Anshadam and Anju for coordinating this CPC, and Dr. Surabhi for the help with these cases. Thank you. I'd like to invite.
Excellent case, I did.
Mike.
Very sad.
So I think it was a direct pathologist doctor. So what was the exact surgical findings? What kind of surgery did you do? How much did you dissect?
Most like incision is the most common part of the tumor, and we just because the sparse was just beneath the active incision muscle. So we made incision there active the muscle to come with the tumor. And in fact, during surgery, I was kind of fleshy. So it's still contemplating that this is sarcoma.
See, so actually I'm afraid because we are putting hand and removing, because it is involving that vessels also. If they are eroded in something, then you are also afraid.
No, so that's what, like,
You won't reach up to that.
that specifically going into the chest, but I said no,
You remained up to the chest wall.
Nowhere we are going into the chest. Whatever is outside, we will take it and submit it for.
I think while doing a differential diagnosis, because whenever my teachers told me about chest lesion, anything can be from the lesion also. That is something, but we did not keep it in mind. But the process are there and
You can see the
So this is yesterday in which so like
I think before the COVID epidemic was sure that could have also been a reason because pandemic to move up he was not steroids.
but this patient was referred from medicine. So
yes,
My
yes.
side
That's I remember. So he had COVID. He was taking cigarettes.
nobody thinks the primary unit that referred this patient. But they should have been here because ultimately we are not going to be able to do anything beyond this.
Even from treatment also, antifungal.
Yes, yes.
antifungal को सभी अभी बढ़ गई है
It doesn't heal on voriconazole. Interestingly, but the other patient is all right. He has gained weight of 4 kgs, improved the appetite. This tumor is not. He's still bothered about the tumor in the leg. So he's on voriconazole.
Increased even on.
He's still on voriconazole.
So don't you think there is a pseudo tumor reaction also? That's because many times because the master removed them just report as pseudo tumors. Maybe the pathologist did not work them out sufficiently to find an underlying inflammatory pathogen which could have been a fungus or mycobacterium or anything which starts this reaction.
But I don't think any drug will bring nothing to the way.
There are necrotic portions they have to be removed.
Yeah, but the point is that you remove this and then where do you end it? I mean, like inside there is everything is destroyed. Currently you are a living patient now.
First nightmare can come.
So you are a living patient, you try to do something and he gets knocked out, something gets knocked out, then he's done for.
So I presume culture was done, no? Because you said it's gutted. So they should do the bacterial culture sensitivity of which drug is causing a response. And if the culture is still there, maybe they can still do because if it's on antifungal and still it is growing. So that's not good. It must have gone. They have mentioned GAT and they have also said that the CSF is positive and some other place is positive.
But I have just one question, whether did you perform any examination under polarized light? Because it's a very nice
Multi-sclerosis. I thought, ma'am, but I forgot.
and I think it's uncommon, but it does occur at times. Because long time back I reported one time where the surgeons were thinking of sarcoma and it translated to
Thank you, ma'am. Thank you. Thank you. Thank you.